And today's actually Addiction Treatment Professionals Day. So we want to thank everybody for joining us. We've assembled a world-class panel of experts to help us do this. We're joined today by BrightView co-founder, Dr. Shawn Ryan. He was inspired to start BrightView when he witnessed how the opioid crisis was impacting communities. Now, nearly 10 years and 100 locations later, he ensures that BrightView maintains its focus on our mission and vision. Julie Raleigh, co-founder and CEO of Madi's Place, has been described as a force of nature, helping create a place where people in recovery can spend free time and avoid a return to use. And finally, we have Tom Synan. He is Newtown, Ohio's chief of police and the leader of the Hamilton County Addiction Response Coalition. He's helping ensure law enforcement, the justice system, and addiction treatment professionals work together in this fight. And with that, I'll let Dr. Ryan begin.
Good afternoon, everyone. Thank you for joining us. We really do appreciate all of you participating today and joining us for this conversation. I have had the pleasure of working with the chief for quite some time and known about our other speaker as well. So appreciate them joining me for this conversation. Just going to run through the agenda for a second, doing some brief description of synthetic opioids to level set. Kind of the basis of the problem that we're in. Many years ago when we started BrightView and I started in the field, we weren't where we're at right now with fentanyl and other synthetic opioids and this complex drug use kind of milieu that just keeps changing, and we'll talk about that a little bit. Spend a little time on harm reduction and what that can mean. It's not a simple term. It sounds like it necessarily, but not always a simple term, or not always agreed upon by folks as to what that can mean. Talk about the unmet need in recovery treatment. One of the things I think that we're drastically underserving the population is with both residential and non-residential environments of sobriety that folks can be in. And so that's a tough topic, and we'll cover it a little bit. The chief will talk about law enforcement's role. I know that, gosh, Tom, was it 10 years? And you still look about the same? I feel like I keep looking older. The chief and I have been through several years and iterations of this work. It started with me prescribing Narcan in the basement of a church in probably 2013 or 14, and talking about, at that time it was definitely a different role for law enforcement than it currently is, and they're thank goodness, much more of a partner these days. We'll talk about some recovery treatment program basics, where we're seeing progress, and then of course Q&A is my favorite time for folks to ask questions about what it is that the three of us, as a multi-pronged approach, the three of us work on every day. Next slide, please. I won't belabor the point. Fentanyl and that class of medications fall under opioids. This is a brief slide about the kind of the differences between opioids and opiates. Some, again, are synthetic, some are not. I think that the summary topic here, I think most of us remember when carfentanil hit the communities, which was and continues to be, if it's ever found, disastrous because of the potency, which you can see on the left, kind of heroin, fentanyl, and carfentanil equivalent dosing in those vials, and the drastic danger that those high potency synthetic opioids can present. Also important to note, and I think this will be a pervasive theme throughout the day, that as soon as as soon as we find something that's a problem, something else pops up. Opioid, non-opioid. We'll talk a little bit about Xylazine today. The reality is, that the science of the frontline folks that are doing resuscitation and the emergency physicians like myself and the scientists really need to be on top of this topic at a chemical level. It is tough because the amount of, whether it's highly educated chemists and pharmacists or artificial intelligence developing new compounds, this will remain a moving target, primarily driven by the demand side of human drug use. And so although there is a very important role for the DEA and law enforcement on the supply side to obstruct as much as they can, I think Tom wears a cape some days, but he just simply and his colleagues simply can't obstruct all of the ways that people can either ship drugs in or make it here in our communities. And so, there's just as many things that are unnamed in the opioid class of drugs than there are that are on these screens, and that'll perpetually be the case, unfortunately. Next slide, please. This is the latest thing to hit the media. I was talking with the other panelists, kind of a pre-session about the fact that we get a lot of questions about what's hitting the streets based on the media. I'd like to just say the media is primarily based, especially on this topic, in the latest and greatest, and social media compounds that. That's not particularly helpful to folks in treatment or in the rest of the recovery work because it's distracting, and so we just need to make sure that we are being mindful so that things like xylazine, what can the medical professionals and first responders do about that? What can the treatment agencies do about that? And being very succinct and not being pulled away from the topic of what their actual issue is, which is we still have a raging, primarily opioid epidemic, a large component of which is synthetic opioids, fentanyl or analogs of fentanyl. And what this drug in particular does is compound that problem at the front lines in treatment, because it makes it chemically more complicated for resuscitation if a person was to have an overdose, and a little more complicated for those treatment professionals to understand how to deal with multi-drug use. Or in this case, one of the things we talk about is, why is broad spectrum drug testing so important? Well, in reality, there's no way to guess what's out there. Law enforcement can't tell us fast enough, and even in working with the drug testing companies like LabCorp, Quest, Millennium, etc., the DEA is finding that that's actually a great way for them to find out what's in the public is to use the drug testing data, because it gives you more sense of what's in a region earlier, and then obviously by the time the coroners correlate their overdose data, it's behind the curve, unfortunately. And so drug testing is one of the few ways, in conjunction with what law enforcement is doing, to really know what's hitting our community and allow the medical, primarily medical providers to know how to respond. Xylazine, I was unfortunate enough to see, some folks in public that had clearly gotten a hold of this drug based on their behavior. Guess we lost our slide there, Kevin.
Let me map back up as we speak.
Thank you, sir. But you may or may not have seen this behavior in public in different communities where folks are basically standing kind of hunched over, but still somehow standing. It's a very bizarre, specific behavior. Xylazine is a alpha-2 acting drug, and it's somewhat similar to the way that clonidine works, which we actually use clonidine for withdrawal management for opioids as a safe, generally safe drug. But there's no known antidote for that question that I'm sure is already on the table. I'm not even, in fact, I'm not really sure how you would develop an antidote for xylazine because of its mechanism of action. It's not like a benzodiazepine, which we have a specific antidote. It's not like opioids, where we clearly have a very specific antidote. And so it's important for folks in the community to know, the first responders, especially, and emergency physicians, what to do, which is primarily CPR and supportive care. So for the public and first responders, Narcan per usual, because if someone is overdosed, opioids are very likely, 90+% chance opioids are a part of that drug use. And then, appropriate CPR and supportive measures, because there's no known antidote for xylazine. In regards to the treatment side of things, which I know is also a question, because we know what the mechanism of action is, we know what medications to use to manage the withdrawal, which could include things like clonidine, benzodiazepines, and in the case that the patients have concomitant xylazine and opioids, which is going to be very common, then we would use a combination of medications. And so I hope all of that is a little educational in regards to this newer, but you saw the trends. It's not new, 2 or 3 years of pretty pervasive increase in that drug being present. And I'm going to stop for questions in a second while we get our slides back up. But, the reality is the most important part of this conversation is the fact that on the first responder side, we got to keep them updated, first responder, emergency medicine, that kind of side of things. Got to keep them updated as to what to do in what setting as fast as we can. It's hard to stay ahead of the curve. The drug dealers are faster than all of us, which is a very unfortunate situation. And most broadly, it's not to chase our tails. And the way not to do that is to have consistent, multidimensional or multi-part treatment that is comprehensive as the programs at BrightView with the medical, psychological, and social components of intervention that make the specific drug use, kind of less of the focus, so that the medical professionals are educated on what to do for acute and ongoing management, but that the psychological and social folks are still doing their piece, so that we're not kind of hitting the nail with only one hammer. And so that's a broad topic where the media gets us, like I said, distracted or discombobulated from the fact that multidisciplinary, multi-component, comprehensive treatment is how we stay as far ahead of the constant and changing drug use that we have. I'll stop for questions to see if anything pops up. We're back on. If you don't mind, we'll hold in for questions. Again, the broad term of harm reduction is a little bit of a complicated topic. In one of I see a quote here, which is not mine, that one of the concepts is to mitigate the damage being done until that person wants to change. I would probably change that quote a little bit and make sure that folks know that is absolutely the point, the general point of harm reduction is to provide people with mechanisms of maintaining their life, whether it be, some of the methods on the right, or safe environments for them to be in, to stay out of, or have less drug use. And we can, some questions may come up about supervised injection sites later. Happy to answer those. But by and large, I want to make sure folks don't get confused about the until that person wants to change piece. Change management and motivational interviewing and moving people from active use to recovery is not always the same. The concept, and I'll always reiterate this, the concept of has to hit rock bottom is garbage, because the rock bottom for a lot of people is the bottom of a coffin. That's not acceptable. And so, any point at which someone can be intervened upon to move them up the motivational chain. So maybe they go from heavy use to less use. Maybe they go from heavy use to directly into residential treatment, kind of high intensity treatment. Those are both fine, but we want to make sure we're not, and this happened, I'll give an example for folks. Within the past year or so, a friend of mine knew a physician that started drinking heavily during COVID, and they never referred him, the friends of this physician never referred him to treatment because they thought he had to have expressed the willingness to change before they would help. That is not correct. That guy died of his alcoholism, and that was a very unfortunate event where folks, these friends of this physician knew me. They could have called me. They just literally like, yeah, I could have called you, but he wasn't ready. Well, that is the wrong way to approach it. So anytime you can even introduce a minor amount or a mild amount of supportive intervention for folks, like just letting them know there's treatment, whatever that intervention might be, that's a great form of harm reduction and helps folks, move along the motivational chain, which is it's not black and white. It's not like yesterday I wasn't ready, today I'm ready, therefore this is the only time you can talk to me. So that's an urban legend. I want to make sure we quell that and make sure that folks understand how important that can be to get into. So very important concept, and I'll finalize by saying we still need more Narcan or naloxone everywhere. We'll perpetually support that endeavor because we will not, I feel like regardless of all the efforts we make, which are a lot of expenditures from resource and finances, we do not have Narcan everywhere it needs to be for every person that could need it. Next slide. I'll turn it over to one of our other panelists.
Hello, everybody, and thanks for joining us this afternoon. Thanks, BrightView, for hosting this. I'm Julie Raleigh. I'm Madi's mom, and Madi's story, I'm going to just give you a little tidbit of Madi. Madi started down the road of drugs and alcohol at the young age of 14. She had a traumatic event that happened to her, and I'm sure most of you guys know a lot of young adults, young children that start down that road have had a sexual trauma, maybe a physical trauma, maybe a mental trauma. Well, Madi had a very awful sexual trauma that she didn't share with us till her junior in high school. And she tried to numb herself with drugs and alcohol. And it just perpetuated. And we lost Madi at the young age of 24. She took her own life. She went in and out of rehabs. But as a young adult, she always described it as, when I get out, Mom, it's like I jump into a black hole. And she's done what everybody said: take her meds, go see her psychologist, her psychiatrist, go to NA meetings, go to AA meetings. But there wasn't, Madi's house was her idea, and we created it in her honor. She needed a place. She always said, if there was only a place out there that I could just hang out and have fun with people like me. My husband and I thought we had her and we could hold her and in and out of rehabs, but being with people that really understand the disease is what Madi saw and needed. And we opened an annex. We've been running out of that for 2 years. We're open in the evenings. We host NAAA support groups, art therapy, dinner and a movie. It gives these young people a place to come and hang out, be with people just like them, get support that they need. And we are very, very blessed that Mercy Health decided to partner with us, because through our 2 years of opening the annex, we have served over 10,000 people, and they've spent over 200,000 hours in a little 2,000 square foot storefront. So this is the home that we're actually sitting in today. We've been renovating it over a year, and we will be able to grow our programming hugely and be able to really even help more and more people. Everything that you get in rehab, our goal is to have outside of rehab, from the art therapy to the yoga to the body, mind, and spirit to outdoor hiking events. We have a gorgeous 4 acres of land. We have a fishing pond that they can come fish. We'll have a pool room where they can play pool downstairs, a full game room. We have a babysitting room that the young adults that have kids, we found that to be a need. We've kind of used our annex as a kind of pilot program, which we didn't kind of go into it looking at that, but we really see what the needs are now. So they'll be able to come in here and sign their kids in and be on campus with their children, and we'll have a safe childcare room that they'll be hosted in with our childcare specialists and volunteers that work. We actually just got a van donated. We've seen that be a stepping stone for some people that don't have a license or can't afford a car, or the insurance or gasoline. So we will have transportation to get you here to and from Madi's house. So we're just really excited to get it open. It'll be open here probably at the end of November, early December, and we'll have our programming up fully ready to love everybody with open arms and hopefully prevent another mom or family from the hole in my heart and my family's heart and all her friends' hearts. We don't need anybody else a part of this club, that is for sure. So we appreciate everything everybody does, from the rehab, all the doctors that help in this addiction, all of our wonderful Toms out there that are fighting the battle too. So we're here for you. And we'll be yelling it from the mountaintops when we get these doors open. So thanks to everybody for all you do for people with mental health and addiction issues.
Hello, everybody. I'm Chief Synan. I am the police chief of a small community just outside of Cincinnati, Ohio, and I have a different kind of outlook on substance use disorder than most in law enforcement. It's from an experience that happened in my community where an entire family, a mother and all three of her sons, had died from addiction. Each one of those sons had kids. Three of them struggle with substance use disorder. That led me to a realization that we in law enforcement don't have the tools, knowledge, and experience to deal with chronic mental medical health conditions. And that led me to Dr. Ryan, who has been not just a friend, but a huge influence and mentor on understanding substance use disorder. He was a significant partner in helping us launch at the time, what we called the Heroin Coalition, now the Hamilton County Addiction Response Coalition. And to his point, we were calling this an epidemic back in 2013, 14, 15 is when we officially launched, with an average of 20 to 25 overdoses. Unfortunately, seeing 1 to 2 people on average die a week from overdoses. And we, especially after fentanyl and carfentanil hit, we bumped up to 50 to 70 overdoses in a week. And unfortunately, 4 to 5 people dying every week. As Dr. Ryan mentioned, carfentanil hit in 2016. In 1 week, we saw nearly 200 overdoses, 40 in a day. Really, not only has the Cincinnati Hamilton County area never been the same, but we as a country have never been the same because of fentanyl. And to his point of xylazine, fentanyl really is the driving force to much of this. And I think what makes fentanyl so different is not just its potency, not just the damage it causes, but its ability to morph into other drugs, cocaine, methamphetamine, heroin, xylazine. In my experience, I've never seen a drug become such a staple in the supply that can be morphed into other things, including fake prescription pills. So it is significant in our area. But we started a coalition with a 12-member steering committee. If you go to the next slide, please. It has now grown, and actually this slide, even though I handed it to him about a month or so ago, is actually outdated. We now have nearly 250 separate organizations, agencies, and nearly 700 people that are affiliated with the coalition. And it really is the power of community coming together to deal with chronic mental conditions, medical, social conditions, stuff that law enforcement often has been put on their plate. But again, gun, taser, handcuffs, and jail don't work with this type of issue. So we look to treatment and support like BrightViews, like Madi's house, those that can take on these long-term support and treatment in order to help make a difference. And this community, last year, it really validated the power of having a continuum care model, treatment, and a support system. If you go to the next slide, please. The power of community is that we've actually seen a reduction in overdose calls. Now I'm going to put an asterisk to that, because just because there's a reduction in calls doesn't mean that there's not necessarily people overdosing, but there's people being revived and there's also some getting connected. But that community group in 2022 actually saw a 16% reduction in overdose deaths the year before and a 24% reduction since 2017, which was the peak. Our current trends right now, and for us, it is not data. It is always remembered that's a mother, father, brother, sister, son, or daughter is a human being, and we treat the human being as a person, and we treat them as a whole. We are seeing in 2023 actually an even lower trend in overdose deaths, and if that continues, we are expecting in 2023 to actually be lower than when we started in 2015 when we officially formed the coalition. So again, partners like Dr. Ryan, partners like Julie, BrightView, all of us coming together as a community has really shifted how we view addiction, how we deal with addiction, and it's made a significant impact. And I would say too that having that group, having that community really helps mitigate the influence of no matter what drug trend comes along, because you have the partners lined up, you have that continuum care model. So no matter what the trend, it's easier to treat that person and substance use disorder as a whole. So I appreciate the time, and I'm looking forward, like Dr. Ryan said, to the questions. That's really where we get the things we need to get to talk about.
It's I'm going to talk about a little bit about levels of care for a second, folks. Why is this? From a general concept and a high level, I'll talk about the importance of this. My colleague, who's joined us as the Chief Medical Officer of BrightView, Corey Waller, has been basically the author with a large team from the American Society of Addiction Medicine of the next stages of kind of the continuum of care. The continuum of care is an important concept because we have it in really every other part of medicine. So if you have genetic or environmental issues that lead to cardiac disease or both, which is often the case, and you show up in the hospital with a heart problem, heart attack, or other issues, we have a whole plan laid out for how we're going to care for you, whether it's admit you to the hospital, do that thing in the immediate, refer you to the cardiologist, they take care of you, refer you back to primary care. There's often nutritionists and other things in that continuum. But at no point is what it is it related to what we currently see in addiction or historically have seen in addiction, where there's, a discombobulated, complex plan for the patient and family to try to navigate without a pretty consistent continuum of what to do. There's only probably a 5 to 10% variance, no matter where you're at in the country, in what kind of that continuum of care looks like for most medical diseases and for most, even for a lot of psychiatric diseases. And so Corey's team and these levels of care, by the way, have been in existence and written by ASAN, the states, a lot of Medicaid programs for years now, but we have not put forth the resources or had the time to develop full continuums in most places. And so people end up, getting on a plane to Florida, which is generally dangerous, or end up in a single, kind of a disconnected detox unit, which may or may not be the right level of care. But all of these things are the right levels of care are known. The science, even before the new criteria come out this year, the science has been known that we need to put people in the right level of care so that they can function well. I'll give you some concrete examples. If you take somebody who has opioid use disorder or other use disorders, but the rest of their life they're holding it together pretty well, which is more common than people think. And you say, you know what, you need 90 days of inpatient. And they're basically just kind of like getting by, paying their bills, paying their rent. Kids are doing okay and going to school. You yank them out of that situation, slam them in residential for 90 days because that's the only thing available or what everybody thinks is necessary, which is not often the case. That person actually does more poorly by the science. They do not do well because you disrupted what stability they had. In contrast to that, if there's no stability in their life, they have no place to stay, kind of a residential recovery setting with treatment or something that is a higher level of care up to and including the hospital, which you can see as a level of care, is absolutely necessary for those folks because of, again, the comprehensive look at that person's life and use disorder, not, like they use opioids, therefore they need, 20 days of detox or whatever. That is not the way to approach people because our lives are more complicated than that. And their chances of recovery are very scientifically and statistically aligned with choosing the right level of care for a patient. And that includes, like I said, our hospital systems who are better than they were 10 years ago, but still have a long way to go. We still have way too many people showing up with serial alcohol use disorder who really need a hospitalization, and the physicians or providers there, we don't know that criteria for what they may need, and they just, kind of say, hey, here's some Valium and come back if you have a seizure. And so this continuum of care concept that is well known in the rest of medicine absolutely has to continue to develop throughout our country. There's very few places in the country I know of that have this whole continuum. We do an okay job in Cincinnati as an example, but that's been 10 years of work. And so we have a long way to go to get people the right level of care. Of note, based on hundreds of thousands of assessments and intakes, only about 1 in 5 people even need inpatient or residential care. And why that's important is because there's never going to be enough beds for those folks. And so we don't need to be shuttling individuals, assuming the public, family, friends, assuming that person needs that level of care, because if we stick them in there, not only will they do poorly, but the person who actually needs it that's right behind them can't get in. And so understanding the complexity of this is something we know how to do. The science is clear. It's going to become more clear with Dr. Waller and his team from ASAM putting out new publication. And as our state Medicaid programs and other insurance companies and communities become aware of that new criteria, it's even more pragmatically and functionally clear who needs to go where, when. But by and large, and one of the reasons that BrightView is focused on outpatient is we can serve the most patients, 4 out of 5 approximately, the best for a long-term recovery goal by starting them in outpatient and then doing the assessment if they don't do well, transition them to a high level of care and then bringing them back down. But again, never letting go. That's really the important part of a continuum of care. You don't just tell, I think it would sound ridiculous. Nobody would accept it if I was an emergency physician and you came in for a heart attack. This is what happened in the 60s, by the way. I gave you some aspirin and morphine and said, probably 1 in 3 chance you're going to die, but take this aspirin and we'll see what happens. Nobody would accept that as a good level of care in the United States today. Telehealth is a long topic, which we're not going to belabor immensely today, but it definitely has taken off, during and post-COVID. And why is that important? Well, it's reality that transportation has historically been the #1 barrier, especially in rural settings, for folks getting good addiction care. I remember when we started BrightView, I'm a math and science nerd and a compulsive reader, if you can't tell. And I immediately started, as we were trying to figure out how to get people better faster, I immediately started reading as much as I could to understand what were the things that people really couldn't do. Why would they not stay in treatment? Because a lot of the assumptions, parents would probably say, I always asked why and never really took their word for it, which is probably painful for them. But I was like, well, why can't they stay in treatment? And literally every study that was ever looked at, and it's still the case, transportation is the #1 barrier to folks staying in treatment. Give an example of an opioid treatment program challenge. It's still the case in most states. Most opioid treatment programs where you can receive opioid use disorder treatment, unfortunately, again, kind of siloed, which is something we're working on. You have to attend 6 days a week for the first 90 days in the first phase of treatment. I don't know about you. I know Tom works out a lot, but if you told me I had to work out 6 days a week for 90 days, I don't know what you would have to offer me to achieve that, but it would be rough. And so to expect people to do that in an already tumultuous life setting with neurochemical imbalance should sound kind of wild that we expect that to be the case. But that's still where we're at today. And it's one of the reasons that BrightView does utilize other medications, including buprenorphine, is because of the challenges with methadone and OTP. And in some settings, buprenorphine is lumped into that 90-day plan. And so telehealth is one of the ways we can adjust for the reality of patients' lives. I've always said for BrightView, and I think people still use the phrase, meet people where they're at. Well, if somebody comes in, and this happened years ago when we were looking at our return rates, and I said, are we asking every person that's leaving on the first day how they're getting back tomorrow? And the answer was not really well enough. I'll put it that way. Because I said, well, if somebody got here through a daisy chain of like 15 rides from 100 miles away, and how do we think they're going to get back? We should have been doing more telehealth then, and I mean the broader topic, not just BrightView, than we do now. And so I have so many examples of the way that telehealth can be appropriately. That doesn't mean just telehealth. We do not support those programs that are as a primary, where they never see another human in person, and they're disconnected only by telephone unless there's no other way to reach that person. The hybrid programming that allows for appropriate in-person management, as well as adjusting for transportation barriers, is really optimal in my mind. I think telehealth is a key advantage we have more of now than we used to. I mean, look at this. Historically, I don't know what it would have taken for me to get, how many participants do we have today? Almost 300 people online. I've spoken in front of hundreds and thousands of people for the past several years. But in reality, those were big conferences with lots of transportation and, everybody getting on planes and whatnot. And so now we have this wonderful, the advance of these wonderful technologies to see patients, and we should utilize those when appropriate to make sure we reach people where they're at, like I said. Next slide. I think I've already said a lot of this. There's no one size fits all treatment, and that's because everybody's life is different. We use kind of a bell curve concept. We want to make sure that we are standardizing treatment. So treatment needs to be individualized, but not haphazard, if that makes sense to folks. You can't do anything somebody needs for all people at all times. You can't run a program like that. You can't track outcomes like that. And you cannot possibly run, really use standards of care like that. So we shouldn't just allow anyone anywhere to do anything. That's not feasible. But we do need to individualize and understand, and you can see here on the right, these are all components of a treatment plan and a recovery program for a lot of folks. And that's fine. Folks talk about the complexities of court order treatment. I think that can be a path to recovery for some people. One of our other executives will commonly quote me in saying it's an and, not an or. And the reason is that's exactly right. It's not medically assisted treatment or NA meetings. It's and. If the patient finds, meets, if their recovery pathway is best met by doing things and including attending places like, or finding safe places to reside or stay for periods of time like Madi's, that's very important. And I think it does none of the groups that provide any of the services on the right, nor the patients, any good to have any infighting about what's better, or we can just do it this way, or we can just do it that way. And the science tells us that, right? This is just math. The success of any one thing on the right by itself is low, period, end of story. And so that doesn't make any sense. And that's why I always talk about and, not or. And so the more we can, as a village, right, can treat folks like that, understanding that we're all working together to improve our communities, the lives of friends, families, etc. This will definitely, and has been, as Tom talked about, all boats rise is the case here. So I think that's a very important concept for folks in the treatment milieu, in the spectrum, in the continuum of care, not to be at odds, because that's not helping anybody. Where are we seeing progress? I'm happy to say, that this is on the right path. I think COVID did a lot of damage, and I want to caution looking at singular graphs. By the way, Hamilton County is a little bit of an exception, Chief, in regards to the rest of Ohio and a lot of areas of the country. And so we are still seeing a consistent or even uptrend in overdose deaths, including opioids, in some areas because of not addressing it as a community in a comprehensive and coordinated way, like a lot of places. Hamilton County had the largest per capita distribution of naloxone a few years ago in the entire country, which BrightView, the University of Cincinnati, and Hamilton County Public Health led. And not surprisingly, as one of many arms, that was an important part of the reductions that we started to see across this time. And so this is reassuring, but I'm cautious because the other graph that's all overdose deaths, drug irrelevant, is not seeing as much positivity. So we're getting a grip on opioids, and I'm really happy to see that. But again, not seeing communities as a whole, not seeing drug and alcohol use as a whole, can be a little bit misleading, so that we, kind of like whack-a-mole. I guess I've heard the chief say that more than once across the past several years. We end up thinking we smashed that mole, and it is coming right back up in another hole. And in this example, if you're not aware, alcohol use disorder is completely on an upswing post-COVID and in general. So we're seeing some, the self-isolation on the top point on the left of COVID was devastating. I had patients one guy was doing really well. But he said being back in his house for however many months at a time made him feel like he was back in prison, and it just destroyed him. We are continuing to work on stigma, and I think we got a long way to go on that, but we're seeing some positive movements, and just even people using the right language. has been a big move for folks. The access to medications has been a huge upswing, both naloxone and the treatment medications, as I mentioned. And in the state of Ohio, we've been very lucky that the previous and current governor, the governor was previously the Attorney General, and all of the legislators have really been very supportive. The Ohio Mental Health and Addiction Services cabinet, and tons of work across the entire state to increase access to evidence-based treatment has been really helpful. Been a lot of policies and bills passed for treatment and prevention. That actually is a lot of what I do now, is national advocacy in Congress to make sure we're continuing to reduce the incorrect rules and increase the resources for substance use disorder and mental health. And so that's been a huge, a boon to the country, and one of the reasons we might be seeing an arrest in this parabolic curve, that I saw. So I graduated medical school near the beginning of this curve on your right, and man, what a terrifying upswing we saw there for so many years. Last thing I'll talk about on this slide anyways is the opioid settlement. And really the thing that I'll say, so many folks are involved in the distribution of a fair bit of money. It's not really that amount of money sounds like a lot, but it's not a lot when you talk about a national epidemic. We spent 500 times that much money on COVID. And so with a national epidemic, it's a lot of money, but it's not enough. And I would just advocate for folks, whoever, wherever you might be involved, if you're a family member or treatment provider of any sort that's involved in these conversations, let's all advocate for making sure that money goes where it needs to go. And I don't really need to belabor that point. We are all, hopefully not as much in Ohio. I think the leadership there is pretty strong, but we're all at a significant risk of seeing a repeat of the national cigarette settlements, the tobacco settlements, where most of the 90-something% of that money did not go towards the things it needed to. But hopefully with this much attention and smart people and effort and compassion, we will hopefully won't go down that rabbit hole again. These are some of the policies that we abide by at BrightView, and hope to encourage other providers. One of the things that I know Tom was there when I first said, hey, we're going to see somebody next day, same day, 24/7 hotline to get in, easy button to send them to treatment in Hamilton County. When I said that in 2015, people definitely thought I was crazy. And that has been the way that we have been operating for this almost decade now, and will continue to do so to the best of our abilities. Eliminate those barriers. Like I described, the transportation barrier. I'll give this one example. Our CEO, Chad Smith, and I sat down when we first started learning how people got to the treatment center in Norwood, where our corporate office is now still located. We sat down and said, what is this Medicaid transportation thing? Man, what a mess. And for folks that have to navigate that while trying to get into recovery, it was very educational. So continue to work on those barriers and all of the things you can see related to that, not denying service for lack of payment and other challenges. And then I already talked about the continuum of care and understanding that there is science and there are models talking about how to do it. It's not easy. All right, we took, let's say, 50 to 60 years to get really good at cardiac care in this country. I don't think it'll take us that long to get better at. Hasn't taken us that long to get better at substance use and mental health treatment, but it's a long road to build those continuums. Just knowing that communication is key, and then also for the folks who are going through programs or in whatever part of their recovery journey they're on. Warm handoffs also include warm touches, and so compassion is really key for folks. I'll tell you, if there's any one factor that I think that has kept people in treatment as much as or more so than our appropriate science-based medications and such, is just letting them know that you do care, about what, how they're doing and where they're going. Thanks. These are some specific bullet points I'm not going to read for you all about recovery and progress that we can continue to do. Stigma is a long-standing and will continue to be so. Supporting innovative program like Madi's House and things that are related to that, like sober living and housing and recovery housing, all of that spectrum of things is really important. It's very hard to stay in recovery if you don't have a safe place to sleep and go. And so, collaboration, communication, and then staying up on, the best and newest programs and treatments, and being objective. I don't work for any pharmaceutical companies. I haven't even spoken for one in a long time. But it's really important to know that, things change quickly, as demonstrated by Xylazine, and we got to be educated to meet them and saying, well, I saw this work 10 years ago for Bob Smith. Not probably a very helpful kind of sentiment, depending on whether that exact case is the same again or what has changed in that time frame. Maybe some learnings from that experience, but trying to place every person in the same box and not looking at the entire list of recovery options is not a great strategy. Next slide, please. I think we're here now. I've got about 10 minutes for Q&A. I will let our moderators manage that and help us address any questions that we haven't already covered.
Thank you, Doctor. Yeah, one of the questions that we have had relates to methadone, and I think it's an important topic too. As part of this, are more organizations looking at methadone maintenance therapy? Are they looking at it differently? Have we noticed a reduction in stigma regarding this treatment? And if so, is this a part of a broader reduction of stigma? I think methadone has been at the heart of a lot of controversy sometimes, or assumptions, stigma, rather, stereotypes. So what have you noticed there?
Yeah, I think all of those questions are valid. I think the stigma continues. Methadone is heavily stigmatized. Most treatment entities that treat opioid use disorder, primarily or even as part of their spectrum, are looking at expanding methadone because we know scientifically that it can be an effective option, not the only, an effective option for those folks who are using synthetic high potency opioids. There's a lot of acronyms for that kind of set of drugs. Again, to Chief's point, primarily fentanyl. And so for me, part of my point about, most of us in the treatment field don't work for pharmaceutical companies. And so we don't have any obligation to talk about which medication for who. We talk about what does the patient need, and if you do the comprehensive assessment and it appears that they, that methadone's the right option for them, if you don't provide it, you need to refer them to someone that provides it. At BrightView, we are expanding our methadone services, and sometimes stigma gets in the way. Sometimes community, issues with methadone, which is challenging, get in the way. But by and large, expansion of methadone is happening. It is appropriate, and we need to continue to work on the stigma associated with that, which has been a little, is pretty multifactorial. And what I mean by that is, the fact that a lot of methadone programs or opioid treatment programs that dispense methadone are in the worst parts of every town, that tells you something by definition, right? And so it should seem a little bizarre that we expect folks who are in a very precarious recovery position to travel through a part of town where they're likely to run into the people, places, and things that they shouldn't be. That should sound bizarre because it doesn't make any sense. Functionally, stigma has definitely put that there's a lot of places in those areas, and so reduction of the stigma specifically around methadone very important, but also understanding that best case scenario is a patient is seen in a program where they have kind of all the options, so that if that is the right one, no one would ever ask me that stuff about diabetes medications, right? That's the expansion. The example I'll use quite often is I don't remember the last time somebody gave me any feedback for the choice of other medications I use, whether it be for weight loss or cardiac disease or whatever else. Unless it was the pharmaceutical rep, and they're like, "Why aren't you writing more of that?" Anyways, that's the only people that ever give us any feedback. But man, do we get it on methadone, and buprenorphine and naltrexone, etc. Next question.
Okay. One of our viewers wants to know, how can we encourage insurance companies to invest more in treatment and recovery? Are there any efforts already in progress?
I'll answer that backwards, and I don't know if the other panelists have any thoughts on, especially on the recovery process. They don't really compensate for very often, or in many ways, for recovery housing or sober environments or anything like that. That's actually a problem. There's progress being made because it's starting to get grouped into social determinants of health, and some of the insurance companies are looking at payment through those mechanisms. But by and large, we all need to advocate for insurance companies to have expanded reimbursement and services for folks in this mental health and addiction crisis. And it's, the fact that if you're not familiar with the mental health parity rules, the federal government's looking at strengthening those because the insurance companies, for whom I do, serve on some of their boards in order to guide them, insurance companies by and large don't invest a large percentage of their funds in this field. And that's problematic because it can be the highest return on investment for everybody. In fact, a dollar in treatment is the highest return on investment for folks for overall health, because of the fact that, and it shouldn't seem weird to think, no one is actively using, xylazine and fentanyl and also, managing their type 1 diabetes well. That's not complicated for most folks to understand. So it's a great investment for everybody. But, just historically has been this sidelined. I mean, if you're not familiar, a lot of insurance companies have literally a separate department that just does the mental health and addiction part, and that's part of the problem. It's a whole person thing, and that's where we really need to go.
Okay, great. We're getting a lot of questions about xylazine, and I think earlier, prior to the start of the webinar, I know, Chief, you had some thoughts on that, and would love for you to kind of share your take on xylazine.
Yeah, we had a pretty robust conversation on this. So I'm in the same camp as Dr. Ryan, and it's kind of strange because law enforcement is one that follows drug trends. And xylazine, although each drug, as you all know, has its own unique symptoms, and in that we probably need to treat differently. We as a coalition are looking overall what we can do to treat the whole person, who we could connect them to. Xylazine for us is virtually not seen on its own. It is almost always with fentanyl. I know there's other parts of the country that are seeing xylazine in pockets on their own. I'm unfamiliar with the actual data. I've seen some data. I've not seen confirmed data on if xylazine is causing overdoses or if it's fentanyl. What I've seen nationally is this kind of mix up and this controversy of it's unclear if it's the xylazine or the fentanyl. Did xylazine acerbate the fentanyl, as many of you know? But what we're pushing out from the coalition is more the wound care and also education. And this isn't just xylazine, and this is kind of what we were talking about overall, is if we stay on the substance use disorder completely, the addiction use completely as a whole, it allows us to respond better. So we educate when it comes to overdoses, if xylazine, or it could be another drug that's on board with fentanyl, not only use Narcan, but be prepared to give CPR and always call 911. Xylazine, obviously with the wound care, has added another layer. But one of the things, we also do this with fentanyl because timing, dosage, and tolerances play a significant role in if someone's going to be recovered or not. I think one of the concerns I have is that Narcan is this miracle. However, it doesn't necessarily work all the time. Timing, dosages, and tolerances play, again, that significant role. So education of giving CPR and calling 911 are significant. And then when it comes to the treatment of xylazine itself or any other addiction, we're turning it over to the experts of BrightView, other treatment facilities, and we're turning the long-term support and care to Julie and Maddie's house. That really is that connection. So from the first responder aspect of it, fentanyl for me is the staple. That is what is causing most of the overdoses and deaths. as each new drug comes, I am looking from an aspect, is that causing the overdoses itself or the deaths? Is it definitive? If so, that's going to change our path. If not, what are the symptoms of each one of those unique drugs? And then we are doing it from an acute standpoint. How do we treat on the street? How do we do prevention on the street? What harm reduction materials and tools can we give? And then we're connecting the longer term services that can help when it gets into those layers and complexities on how to treat it. So hopefully that helped out a little bit.
Definitely. Yeah, I think it did. Based on some of the questions we're seeing, I do think it helped. And Julie, we have a lot of folks that are thankful for you sharing your story. Are you aware of any, because we do have folks tuning in from outside of Ohio and the greater Cincinnati area, especially. Are you aware of any programs like this elsewhere around the nation as you've been, in startup mode and now are kind of have your feet under you? Have you learned about any other similar programs?
We did visit one place similar, but not completely what we're doing, called The Zone in Atlanta. They lost their son to a heroin overdose. So they really are doing a little bit of what we're doing, but strictly for the heroin user. So ours is more just all mental health, all anybody addicted to drugs, and our programming is it's all free. We're right here for you. And just like I said, anything you get in rehab, we're going to have outside of rehab. And it's a family disease, as we all know, and it's a chronic disease. And we're here for the family. So we encompass everybody and put our arms around the whole thing and just keep building that bridge to healthy. Like Tom said, it starts with law enforcement, and then, it's getting into a rehab facility like a BrightView. And then we're the next ones to keep catching you and keep building on your recovery to help you as the ultimate goal of all of us is to have you recovered. But we know every day you got to be armed, you got to wake up. You don't know what the war is going to be like outside. You don't know what the triggers are going to be. We want to keep giving you the tools and a place to come to make you successful in your road to recovery.
That's great. Yeah, and you mentioned the other program, the Zone, focusing on just on heroin. That actually is kind of a segue for another question from the audience regarding, fentanyl and xylazine. Patients can unknowingly or unknowingly be using fentanyl or xylazine, right? And they decide they want help. Do they present themselves differently than, say, a non-synthetic, natural opiate? Do they present themselves in a way that you can tell, do we need to treat them differently, or is it a similar level of care that we recommend?
Yeah, I guess I would say we call those things toxidromes. Toxidrome means what are the set of symptoms related to a certain chemical or set of chemicals. And so, the medical professionals can ascertain with the patient's input, in their presentation, what may be the set of things that they're under the influence of or withdrawing from. But unfortunately, to the Chief's point, half the time they don't know, right? And so that's where some of the toxicology testing comes in for us. It has to be very high level scientific, and again, it's tough to keep up with the latest and greatest drug out there. But we have to use all of that. So the medical knowledge base, the patient's presentation in history, and then we do our best to combat their withdrawal and place them in a level of care that's appropriate. Again, it does take a pretty comprehensive and knowledgeable medical assessment and professional to do these kind of things, and the federal and state governments are really supporting some of the workforce development in order to do that. But by and large, unfortunately, someone like myself with thousands of hours of experience on the topic is not always readily available. So we, as a medical community, providers, and BrightView is lucky to have we use Microsoft Teams for clinical communication. We can ask 50 people at once, like, hey, what are you seeing? What'd you do? Here's my clinical question. I think we need more communication and education programs around to help providers really figure out how to, again, really know that continuum of care, what pieces of it are available in your community, how do you communicate and get, and there's some programs for specialty consultation outside of your entity through the different societies like the the AAAP, American Association of Addiction Professionals and such and so on. So, or excuse me, addiction psychiatrists. So a little bit of a complicated answer, but it's tough out there, trying to make sure you know what the patient is coming in for, what they think they do, and what they need in order to treatment level of care.
Okay, we have one more point actually to add from a attendee. Actually, they mentioned that Tyler's Redemption Place in Akron, Ohio, is also a similar in ways to Madi's place. It's started by a family that unfortunately lost a child. They built a center for recovering programming and family support. And then moving to our final question, why isn't there mandatory treatment after a first responder response to an overdose case?
So I can kind of take that on. I help rewrite Casey's Law in Ohio, as Casey's Law in Kentucky. There is, as with everything with this topic, there's a ton of complications. It is extremely complex. One, from the first responder side, some of the pushback, and Dr. Ryan was in some of these meetings, especially in the beginning, there was pushback on law enforcement from civil liberty groups, which makes sense. When you have a law enforcement officer forcing someone into something, that has its own constitutional challenges. We worked on, can families, can guardians, can doctors be able to do that? And that was kind of our push. It works really well in Kentucky, where the court system, along with medical professionals, dictate a plan for somebody, keep them in long term. But here's the thing, Kentucky has statewide resources that they're using. So the system is very, to everyone's point today, there is a continuum care model all the way from the first interaction to the family appearing in front of the doctor and the judge. There is a plan that's set out, and that plan is worked on all the way towards active recovery. Ohio, unfortunately, has several more barriers than that. It is not a statewide system. And it basically, in the beginning, it was the family, the parent, or the guardian that had to pay for everything. You had to make sure that there was a facility open. You had to design the plan. We've changed a little bit of that, and that the courts are now more willing on a probate side, on the civil side, to work with the medical community. However, it's extremely challenging to get someone into the court system because a doctor has to basically initiate it from a family member. And also there's insurance, Medicaid, someone has to pay for it. There's not a statewide system that's supporting it. So it is a challenge, and I'll give you another layer of this that kind of, in my opinion, goes to stigma, and that's from the political side. Much of the pushback that we received on this law was there is still a lot of, especially on the political side, that believe you must punish someone before you give them the carrot, that you have to have them sit in jail, go to court, be in front of a criminal judge, have that criminal charge, quote unquote, over their head in order for them to get treatment. Myself and many others pushed against that. However, it was extremely challenging and very difficult to overcome on the political side. So as much stigma as there is, there's still this underlying political base that says punishment first, then treat. My thing was, why don't we try to give someone care first, and let's take out the punishment part. I think we've been doing this drug war thing for probably 80, almost 100 years. It has not went very well. You would think we'd be more willing to change. However, there is still that strong group, but there's people like Dr. Ryan, Julie, and many others who continue to push to make improvements. But from a political side, short answer, it's extremely challenging and complex for law enforcement, from the first responder, just to do it. There are laws in place. They don't work really well. I would love to see the community and mothers and parents get together and work more towards this legislation instead of people like Dr. Ryan and myself and some others. I think when the community comes and tells elected officials, this is what we want, that's where you see the greatest change.
That's great. That's a great point. As you pointed out, also it is complicated, and it's great that we have a variety of efforts, including families, working together, like Julie's with Madi's house. Dr. Ryan pointed out that we need more communication and education around these topics, and we certainly appreciate everybody tuning in today to do just that around this. So really appreciate everybody attending today, and hope everyone has a great day. Thank you.
Thank you, folks.